Welcome back to the deep dive. Today, we are not just skimming the surface, we are strapping on the heavy gear and descending into something truly foundational.
We really are. We're pulling a very heavy, very dense book off the shelf.
Specifically, Snell's Clinical Anatomy.
It's a classic, a heavyweight in every sense of the word, and we're cracking open the chapter on the upper limb.
Now, for anyone listening, that might sound, a little dry.
Oh, yeah.
Yeah.
You might be thinking, great, an hour about the elbow.
But the upper limb chapter isn't just a list of bones. It's really the instruction manual for how human beings interact with the world.
Exactly. It's how we touch, hold, build, and, well, break things. But before we get into the nerves and the mechanics, we need to set the scene. We have a bit of a mission statement for this deep dive. We were looking through the source material, and there's this underlying sentiment, and I think we both feel this, that reading, true deep reading of anatomical texts is becoming a bit of a lost art. It really is.
Yeah.
We live in this age of quick digital summaries, 3D anatomy apps, 5-minute YouTube videos. And those are great tools, don't get me wrong.
They are. They help with visualization.
But there is a depth of understanding, a nuance to the why and how that you only get from really sitting down with a text like Snell.
So, to be absolutely clear to you listening right now, this deep dive is our interpretation. We're going to unpack the key concepts, the aha moments, and, the clinical anchors. We want to make this material digestible.
And fun, hopefully.
Fun. But we are not replacing the book. Our goal is that by the end of this conversation, you are going to be so curious about, say, the brachial plexus or the anatomy of the snuff box that you actually go find the book, open it up, and look at the diagrams yourself.
Consider this your roadmap.
Not the territory itself.
Well said. We want to turn the rote memorization of anatomy into the understanding of function. Because when you understand function, you don't have to memorize nearly as much. It just makes sense.
Okay, let's unpack this. And the best way to start, according to Snell, is with a story, a clinical case.
Always the best way.
I'm going to read this case study directly from the source material because it sets up everything we're going to talk about today. I want you to picture this scene in your head, like a movie.
Yes, hear it.
A 64-year-old woman falls down a flight of stairs.
A classic mechanism of injury.
She's admitted to the emergency department with severe left shoulder pain. Now visualize her posture. She's sitting up on the gurney, but she is holding her left arm with her right hand.
Okay.
She is literally supporting the weight of her injured arm because her muscles refuse to do it.
That's a massive visual clue right there, out of the gate. She is splinting it herself. That tells you the structural integrity of the shoulder girdle is, well, it's compromised.
The clinicians step in to inspect the shoulder. They see a loss of the normal rounded curvature. That nice round shape of the deltoid is just gone. It looks flattened.
Flattened, okay.
There is a slight swelling just below the left clavicle, but here is where it gets really interesting. They test her sensation.
The neurology.
She has severe sensory deficits, numbness on the back of the arm, the forearm, and parts of the hand.
So immediately, the plot thickens. We've moved beyond a simple bone problem.
Far beyond.
We have a bone problem and we have a nerve problem.
The diagnosis. Subcoracoid dislocation of the left shoulder joint, complicated by damage to the axillary and radial nerves.
This is exactly why anatomy matters. I mean, if you just look at the x-ray, you see the bone is out of place. You might think, okay, pop it back in, job done.
Right.
But if you don't know your anatomy, you might miss the fact that the head of the humerus, when it popped out of the socket and went down, it smacked directly into the axillary and radial nerves.
And if you miss that...
If you miss that, you miss the diagnosis, and that patient could lose function permanently. It's that serious.
And that's our roadmap for today. We are going to deconstruct the upper limb so that you, the listener, can solve a case just like that one. We're going to start with the bones, move to the wiring, the nerves, and end at the hand.
Let's do it.
Okay. Section 1, osteology. The bones. But we are not just listing names in Latin here. We need to talk about what the text calls the danger zones.
Right. To really understand the upper limb, you have to realize it's basically a multi-jointed lever. Its entire evolutionary purpose is just to put the hand in a position where it can manipulate tools, grasp objects, or, perform fine motor tasks.
So the shoulder, the elbow, the wrist?
They're just the crane that moves the cargo, and the bones are the framework for that crane.
So let's start at the attachment point to the body, the clavicle. Snell calls it the strut.
And it really is a strut in an architectural sense. Think about it. I want you to touch your collarbone right now. That bone is the only bony link between your entire arm and your trunk. That is it.
That's kind of amazing when you stop to think about it.
It is. If you didn't have a clavicle, your shoulders would just collapse inward onto your chest. It holds the arm out laterally so it can move freely away from the body.
And because it's the only link, it takes a massive beating during any kind of trauma.
Precisely. It's a force transmitter. If you trip and fall on your outstretched hand, that force travels up your hand, through the forearm, shoots through the elbow, travels up the humerus, and then slam. It hits the trunk via the clavicle.
Which is why it's the most commonly fractured bone in the body.
It's the bottleneck for all impact.
And Snell is very specific about where it breaks. It's not a random event.
No, it breaks at its weakest point, which is the junction of the middle and the outer thirds. It's just simple physics. That's where the S-curve of the bone changes shape. It's almost designed to buckle there, like a crumple zone in a car.
To spare the more vital structures behind it, like the lungs and major vessels.
Exactly, a life-saving design flaw.
Okay, moving laterally to the scapula, or the shoulder blade.
Yeah.
The source material notes that scapular fractures are actually quite rare.
Oh, they're very rare. The scapula is this flat, triangular bone, but it's completely encased in these thick slabs of muscle. The rotator cuff muscles, the trapezius, it's basically floating in there, all protected.
So if you see a patient with one...
If you see a patient with a fractured scapula, you need to be very, very worried.
about their shoulder.
Worried about their life. It implies severe trauma. We're talking car crashes, high-impact injuries. It takes a tremendous amount of force to break a scapula.
It's just a red flag?
It's a huge red flag. If that bone is broken, you have to check for broken ribs, punctured lungs, or even spinal damage.
Now let's talk about the big one, the humerus, the long bone of the arm.
The humerus is fascinating because clinically, you should think of it as a road that nerves travel along. And there are specific accident zones where the nerves are right up against the bone.
Like a cliffside highway.
Exactly. And if you break the bone at a specific spot, you can predict exactly which nerve is damaged. It's just geography.
Okay, let's break down these zones. Zone 1, the surgical neck.
This is right at the top, just below the ball of the joint. It's called the surgical neck because it's the most common place for it to break in older people.
And the nerve.
The axillary nerve. It wraps right around the surgical neck like a necklace. So you fracture the surgical neck, you damage the axillary nerve.
And what does that look like in a patient? If I'm looking at them, what can't they do?
Well, the axillary nerve powers the deltoid muscle.
Yeah.
So the patient will have a paralyzed deltoid. They won't be able to abduct or, lift their arm out to the side.
And there's a sensory component too, right?
Yep. You'll also see a loss of sensation over the regimental badge area of the shoulder, that little patch of skin on the side of the arm where a soldier's badge would sit.
Okay, zone 2, the shaft of the bone, the middle part.
Here, you have the radial nerve. It sits in a literal groove on the back of the humerus called the spiral groove. I mean, it is hugging the bone tight.
So if you snap the shaft of the humerus, especially in the middle...
You stretch or tear the radial nerve.
Yeah.
It's almost unavoidable.
And the result?
Wrist drop. The radial nerve is the great extensor.
Okay.
It controls all the muscles that pull your wrist and fingers back. If that nerve is out, gravity takes over, and the hand just hangs limp. You cannot extend it.
Very clear. Zone 3, the bottom of the bone, the medial epicondyle.
Most people know this as the funny bone.
Right.
The ulnar nerve runs right behind that bony bump on the inside of your elbow. It's very exposed there. You can feel it.
So if you fracture that area...
You get ulnar nerve damage.
Which leads to the claw hand, which I think we'll get to later.
We will. But the key takeaway here is this. Where the bone breaks tells you which nerve is at risk. Surgical neck, axillary, midshaft, radial, medial epicondyle, ulnar.
Okay, time for a check-in question. We want to make sure this is sticking. I want you, the listener, to pause and think about this for a second. Based on what we just said, if a patient comes into your clinic and they have broken the shaft of their humerus right in the middle, which nerve is most at risk and what movement would they lose?
Think about that spiral groove. Think about the great extensor.
The answer is the radial nerve. And they would lose extension. They would have wrist drop. If you got that, you're on the right track. If not, just rewind and listen to that road metaphor again.
It's crucial. These aren't just dry facts for an anatomy exam. These are diagnostic tools you will use every day in the field.
Let's move down to section 2, the shoulder complex and the axilla. We hear about the rotator cuff all the time, usually because some pro athlete has torn it, but what actually is it?
It's a group of 4 muscles. We use the acronym SITS.
SITS.
Supraspinatus, infraspinatus, teres minor, and subscapularis.
And what is their actual job? Are they for heavy lifting like the biceps?
Not really. They are the stabilizers. The shoulder joint is incredibly mobile, like a golf ball sitting on a tee. The ball is the humerus head. The tee is the very shallow socket. It's designed for mobility, not stability.
So it's very unstable.
Very. The rotator cuff muscles are like dynamic ligaments. They form a cuff around the head of the humerus and hold it tight against that socket, while the big muscles, like the deltoid and pectorals, move the arm around. They fine-tune the movement.
The source material describes a very specific clinical scenario here called rotator cuff tendinitis and something called the painful arc. This was fascinating because it explains why some movements hurt and others don't.
It's pure mechanics. So the supraspinatus tendon, that's the S in sits, it runs through a very tight space right under the acromion.
The acromion being the bony point of your shoulder.
Exactly. If that tendon gets inflamed or swollen from overuse, it doesn't fit well in that space anymore.
It gets pinched.
It gets pinched.
Yeah.
When you lift your arm out to the side, the humerus rises up. There's a specific range, usually between about 60 and 120 degrees of abduction, where that swollen part of the tendon physically scrapes against the bone above it.
So a patient can lift their arm a little bit, say from 0 to 60 degrees with no pain at all. Then suddenly, in that middle range, ouch! It's agony. And then if they push through and go all the way up past 120 degrees, the pain might actually stop.
Yes, because the bone has cleared the tendon. That is the painful arc. It's a classic sign of impingement or tendinitis. If the pain is only in the middle range of movement, you know exactly which tendon is angry and where the problem is.
Okay, let's move on to the axilla, the armpit.
Which is really a pyramid-shaped tunnel. It's not just a hollow space with some hair in it. It is the gateway.
The gateway to the arm.
All those major nerves and blood vessels we're talking about have to pass from the neck, under the collarbone, and through this armpit tunnel to get down into the arm. It's a critical choke point.
And Snell mentioned something very important here regarding the breast. It feels like a bit of a detour, but it's vital.
Yes. While the breast isn't part of the limb itself, its lymphatic drainage, the fluid drainage system, goes primarily into the axillary lymph nodes. About 75% of the lymph from the breast drains right into the armpit.
Which is incredibly important for cancer staging.
It's everything for cancer staging. If breast cancer spreads or metastasizes, it often goes to the axillary nodes first. That is why checking the armpit for lumps is a standard, essential part of a breast exam.
So you aren't checking the arm, you're checking the drainage system of the chest wall.
That's exactly what you're doing.
Right. Now brace yourselves. We are entering the territory that I think strikes fear into the heart of every single first-year medical student.
I know exactly what you're going to say.
The brachial plexus, the wiring.
It is intimidating. On the diagrams, it looks like a bowl of spaghetti that someone's thrown against a wall.
It really does.
But we can demystify it. The brachial plexus is just the network of nerves swapping fibers to create the final terminal nerves that control the arm. It's the junction box.
Snell breaks it down into a sequence: roots, trunks, divisions, cords, branches.
And there's a mnemonic for that. Read that damn cadaver book.
Oh.
Roots, trunks, divisions, cords, branches. It starts at the neck, using nerve root C5 down to T1, and it ends in the arm, as the nerves we all know, the radial, the median, the ulnar.
Let's look at what happens when this wiring goes wrong. The source material details two very specific injuries that have these classic distinct looks. The first is Herb Duchenne palsy.
This is an upper plexus injury, so it involves the C5 and C6 roots, the very top of the network. The mechanism is usually an excessive separation of the head and the shoulder.
Like a difficult birth.
Exactly. That's the classic example. Imagine a baby's shoulder gets stuck behind the mother's pelvis during delivery, and the clinician has to pull on the head to get the baby out. You stretch the neck away from the shoulder, rip, you tear the upper roots.
Then in an adult.
In adults, say, falling off a motorcycle and landing hard on the shoulder while your head snaps the other way, same mechanism.
And what is the result? The book calls it the waiter's tip hand.
Right. So you lose the muscles that lift the arm up and rotate it outward. So the arm just hangs limp by the side and it's rotated internally. The wrist is flexed. The hand looks like a waiter discreetly hinting for a tip behind their back.
That's such a vivid, unforgettable image. Waiter's tip equals upper plexus equals Erb's palsy.
You'll never forget it.
Now, let's contrast that with the lower plexus injury, Klumpke's palsy.
This is the opposite mechanism. It happens with excessive abduction. So imagine falling from a tree and catching a branch on the way down, so your arm is yanked violently upward over your head.
Ouch.
That tears the lower root, T1. Now, T1 is really important because it's responsible for the intrinsic muscles of the hand, all the small, fine muscles between the bones that let you spread your fingers and control fine movement.
And this leads to the claw.
Yes. Without those small muscles to balance things out, the big extensor muscles in the forearm take over unchecked. The knuckles hyperextend, they bend backwards, and the fingers flex. It creates this claw shape. It's a devastating injury for hand function.
Okay, so let's do another check-in. A baby is born after a difficult delivery where the shoulder was pulled, the arm is hanging limp by the side, and it's rotated inward. Is this an upper or lower plexus injury?
Look at the posture. It's the waiter's tip.
So it's upper. It's herbe du chien.
Precisely. If the arm had been yanked up, you'd think lower. But hanging down, rotated in, that points straight to the upper roots being gone.
Okay, we are moving down the limb. Section 4. The arm, elbow, and forearm. There is a concept here that Snell emphasizes very heavily. Compartments.
This is so crucial for trauma. The arm isn't just a bag of meat where everything floats around. The muscles are packed into these tight groups, and each group is wrapped in deep fascia.
Fascia being this tough, fibrous, non-stretchy sheet of tissue.
And non-stretchy is the key word. It's the problem.
Explain that.
Think of it like wearing a leather suit that's 2 sizes too small.
Yeah.
If you have bleeding or swelling inside one of those compartments, maybe from a fracture or a bad crush injury, the pressure starts to build up, and it has nowhere to go because the fascia will not expand.
This is compartment syndrome.
It is a true clinical nightmare. As the pressure rises, it first collapses the veins so blood can't get out, the arm swells even more. Then the pressure gets so high it collapses the arteries, blood can't get in.
And the muscle starts to die.
Muscle tissue begins to die within 4 to 6 hours. Nerves die too. It is an absolute race against time.
How do you diagnose it? Snell lists some very specific signs.
The classic sign is pain that is completely disproportionate to the injury. If you have a simple fracture, but the patient is screaming in agony despite morphine, you have to think compartment syndrome.
But there's a more reliable sign.
Yes, the gold standard test is pain on passive stretch.
Explain what that means.
Okay, let's say the anterior compartment of the forearm is swollen. The muscles in there are the flexors. They're the ones that curl your fingers. If you, the doctor, grab that patient's fingers and gently straighten them, passively stretching those muscles, and the patient screams in pain,
that's a positive sign.
that's a huge positive sign. The muscles are ischemic. They are starving for oxygen. Stretching them hurts like crazy.
And the treatment, there's only one.
You have to cut it open. It's called a fasciotomy. You make an incision and slice that tight fascial sheet from top to bottom to release the pressure immediately. The muscle literally bulges out, the pressure drops, and the blood flows back in.
Snell also warns about checking the pulse. There seems to be a myth that if there's a pulse, you're okay.
Yes, and that myth is dangerous. Do not wait for the pulse to disappear. Loss of the pulse is a very, very late sign.
So the damage is already done by then.
The damage is done. The arteries can run between compartments or just have higher pressure. You can have a perfectly strong pulse at the wrist while the muscle right next to it is rotting and dying. If you wait until the pulse is gone, the arm might already be dead.
That is a terrifying but incredibly important lesson. Pain on passive stretch beats the pulse check every single time.
Every time.
Let's talk about something a bit more common. Tennis elbow.
Lateral epicondylitis. This relates to the elbow region. The lateral epicondyle is that bony bump on the outside of your elbow. It's the anchor point for all the extensor muscles of the forearm.
Common in violinists and tennis players, obviously.
But also coders, painters, anyone who does repetitive wrist extension. You get these little micro tears in the tendon, right where it attaches to the bone. It's extremely painful to press on that spot, or even just to lift a coffee cup.
And briefly, the cubital fossa. That sounds like a geographic location on a map.
It basically is. It's the triangular hollow on the front of your elbow, and it's valuable real estate.
Why is that?
Because it contains the median cubital vein, which is usually where you get blood drawn, and the brachial artery, which is where we place the stethoscope to listen for blood pressure. Knowing the boundaries of this triangle is nursing 101. If you miss the vein, you might hit the nerve or the artery, and that's a bad day.
Okay, check-in question time. You have a patient with a swollen forearm who is screaming in pain when you gently move their fingers. The pulse is still there. Is everything okay?
Absolutely not.
Oh.
No way.
Why not?
Because pulse loss is a late sign. The pain on passive stretch is the alarm bell. It tells you this is likely compartment syndrome. You need to act now, call the surgeon, or they could lose their arm.
Section 5. The wrist and hand. This is where human evolution really, really shines, isn't it?
The hand is an absolute masterpiece. It separates us from almost every other species on the planet. But structurally, it has some serious choke points, and the biggest one is the carpal tunnel.
We've all heard of carpal tunnel syndrome, but anatomically, what is actually happening inside the wrist?
The carpal tunnel is literally a tunnel. The floor and walls are made of the carpal bones, the wrist bones, which form this concave arch. The roof is a very thick, unyielding ligament called the flexor retinaculum.
Because it's a fixed space, it's a rigid box, it can't expand.
And it is packed. You have 9 long tendons that flex your fingers running through there, plus one major nerve, the median nerve.
So if those tendons get inflamed from, say, typing all day,
they swell up, but the tunnel doesn't get bigger, so the median nerve gets squashed flat against the roof.
And what are the symptoms? Snell is very specific about the distribution of the numbness.
Yes. Pins and needles, but only in the lateral 3.5 fingers. That's the thumb, the index finger, the middle finger, and half of the ring finger. That is median nerve territory.
So if the pinky finger is numb...
It is not carpal tunnel. That's the ulnar nerve. That distinction is absolutely key for diagnosis.
And if it gets really bad, if it's left untreated...
You get muscle wasting. Specifically, the thin arm muscles, that fleshy pad at the base of your thumb. Those muscles are powered by the median nerve. If the nerve dies, the muscle atrophies. The thumb gets pulled flat against the hand. It can no longer oppose the other fingers.
And this leads to the term ape hand.
Right. It sounds a bit harsh, but it describes the anatomy perfectly.
Yeah.
Apes don't have opposable thumbs like we do. Their hands are much flatter. So a severe chronic median nerve injury results in a hand that looks like an ape hand, because the thumb loses its ability to swing across the palm.
Okay, now, I want everyone listening to do something. Extend your thumb out to the side like you're hitchhiking. Now look at the back of your wrist, right at the base of your thumb. You'll see a little hollow depression there.
That is the anatomical snuff box.
Why on earth is it called that?
Because historically, people would place snuff, which is powdered tobacco, in that little hollow to sniff it. But clinically, it's a huge danger zone.
And this is for the scaphoid bone?
Exactly. The scaphoid is one of the carpal bones, and it sits right at the floor of that snuff box. It is uniquely vulnerable. If a young adult falls on an outstretched hand, they very often fracture the scaphoid.
And Snell warns about a very specific and dangerous complication here called a vascular necrosis.
This is a real gotcha in anatomy, and it's a common exam question. The blood supply to the scaphoid bone is, it's tenuous. It enters from the distal end, the far end, and flows backward toward the arm.
That seems like a terrible design.
It's very tricky. If you break the bone in the middle, at its waist, you completely cut off the blood supply to the bottom half. That bottom half, the proximal fragment, can starve and die. That is a vascular necrosis. The bone literally crumbles and rots away.
And the kicker is, these fractures often don't show up on x-rays right away.
Exactly. A patient falls, they have tenderness and pain right in that snuff box, but the x-ray looks normal. If you send them home without a cast saying, oh, it's just a sprain, the bone fragments move, the blood supply is cut for good, and you end up with a dead bone and a ruined wrist.
So what's the rule?
You have to treat snuff box tenderness as a fracture until proven otherwise. Put them in a cast and re-x-ray them in 10 days.
Let's do a quick fire revision of the nerve hand signs, because these are classic exam questions and really useful clinical markers. I'll say the sign, you tell me the nerve and the deficit.
Ready.
Wrist drop.
That's the radial nerve. It usually happens at the spiral groove of the humerus. You lose your extensors, you can't lift the wrist or fingers.
Claw hand.
That's the ulnar nerve. Usually an injury at the elbow, at the funny bone, or at the wrist. You lose the small intrinsic muscles of the hand, so the last 2 fingers curl up into a claw.
Ape hand.
That's the median nerve, either from a severe carpal tunnel syndrome or an injury at the elbow. You lose the thumb muscles, the thenar eminence wastes away, and the hand goes flat.
And a quick note from the expert in the text, stop using numbers for fingers.
Yes, please. Finger number 2 or finger 4 can be so confusing. Is the thumb number 1? Or is the index finger number 1? It leads to surgical errors.
So just be clear.
Be crystal clear. Just say thumb, index, middle, ring, little. It's safer for everyone.
We're reaching the end of our dive. I want to circle all the way back to that 64-year-old woman from the intro.
The one who fell down the stairs.
Now that we've walked through all the anatomy, her symptoms tell a complete logical story.
It all connects perfectly. She had a flattened shoulder.
Right.
That's because the head of the humerus dislocated, and it wasn't there anymore to push the deltoid muscle out.
She had numbness on the shoulder.
That's the axillary nerve, which wraps right around the neck of the humerus, getting crushed or stretched during the dislocation.
And she had numbness on the back of the hand.
That's the radial nerve, which was also likely compressed or stretched up in the axilla or the upper arm when everything went out of place.
It's like Sherlock Holmes. The symptoms are the clues, but the anatomy is the logic that connects them all.
That is the absolute essence of clinical practice. Anatomy isn't just about naming parts. It's about understanding relationships.
So here is our final call to action for you listening. We've given you the map, but you really do need to walk the territory yourself. If you are a student or even a professional who's a bit rusty, go open the upper limb chapter in Snell's Clinical Anatomy.
Specifically, find that brachial plexus diagram. Trace the lines yourself from C5 all the way to the radial nerve, and look at the sensory maps of the hand. It's one thing to hear us say median nerve. It's another thing entirely to see exactly which patch of skin it powers.
Reading, as we said, is becoming a lost art, but it's the only way to get the fine details that can save patients. Don't just rely on the summary. Use this podcast to fuel your curiosity to go and read the primary text.
Absolutely. The book is the source. We're just the guides.
To sign off, we have a provocative thought for you to mull over. We talked about the human hand being this pinnacle of evolution. It allows us to build civilizations, play the piano, perform surgery. It's defined by that opposable thumb. But consider the trade-off. To get that incredible dexterity, we have this complex network of long, delicate nerves that have to travel all the way from the neck. They are exposed at the funny bone, they are squeezed into the carpal tunnel, they are wrapped around bones that are prone to breaking.
Right.
So the question is our complex dexterity essentially a trade-off for anatomical vulnerability? Are we fragile because we are so capable?
It's a trade-off I think we're all happy to make, but it certainly keeps orthopedic surgeons in business.
That it does. Thanks for diving in with us. Go read the book. We'll see you on the next deep dive.